There you go. I heard it.
I heard it. Thank you. Thanks, Trish.
Thank you, Deborah. Thank you for the introduction. I'm going to keep my video off for the moment for fear that I am going to destroy the Zoom. So I'm going to keep it off for the moment. I may be brave if this continues to work well and turn it on, but for now I'll keep it off because I'm just grateful I got the slides up. So thank you all for bearing with me. Huge apologies for taking up time on a Sunday afternoon. But really a pleasure to get the opportunity to speak with you all today. As Deborah mentioned, I have had the pleasure of speaking with the group before. It really is a lot of fun and very rewarding, great questions, great discussion. So I'm looking forward to presenting again today on the topic of home dialysis. And I want to make it both an informational session about home dialysis, but also a call to action on some of the things that I think we all can do as members of the kidney community to help with bringing the options of the various types of dialysis that you can do at home to more people. So with that, I will go ahead and see if I can manage to advance the slides. It looks like they're advancing. Deborah, have I advanced the slide? I think
yes.
Yes.
Okay, perfect. So before we even go to things like dialysis, mission number one, the most important thing to know as a person who might have kidney disease is number one, let's protect those kidneys. The various things that we can do for advanced chronic kidney disease are important. They're important to know about, but really, if you're getting kidney care from a nephrologist and other nephrology professionals, the first and foremost thing is let's keep your own kidneys working. Let's keep them working well. Know what's causing your kidney problems. So this is an important question to your nephrologist. If you don't know what the cause of your kidney problem is, ask your nephrologist to clarify for you. It's really important to know, is your kidney problem, gosh, is it from diabetes? Is it from high blood pressure? Is it from something like a genetic condition like polycystic kidney disease? Is it an autoimmune condition like lupus? It's important to know what it is that's causing your kidney problems, because once you know what it is that's causing those kidney problems, then you can get a better sense of, what's the prognosis? How is this going to go? And what are my treatment options? And when you know what you have, then you can get a good handle on what your treatment options are and what are those things that can protect your kidneys and keep them working. Now, our therapies are not perfect. So there are going to be folks who unfortunately do have progressive kidney disease. And that is not what we want to see as kidney professionals, but sometimes it does happen. And it's important to know that you've got options. You've got options if your kidney disease does progress. And there are a lot of options. It's important to know about them. And I've kind of got here on the slide an outline of what there is. And you can kind of see here, they run the whole gamut. They run from kidney transplant, which you can get either from a living donor or by going on to the deceased donor list and receiving a kidney from someone who passes away. There is peritoneal dialysis and home hemodialysis, both types of dialysis that can be done at home. And we'll talk more about those options in coming slides here. And there's in-center hemodialysis. This is a type of dialysis where you actually travel back and forth between a dialysis center to receive hemodialysis, the blood kind of dialysis. And then there's conservative care. It's called a number of different things, but this is care without dialysis or kidney transplantation for someone with advanced kidney disease, perhaps who is older, lots of medical problems, who opts not to do dialysis care, because all of these things come with their burdens, their risks, their benefits. So for some people, the right thing is not to do a type of dialysis or pursue a kidney transplant. And really understanding all these different options from your nephrologists, in particular, in relationship to your particular situation, with your goals for your life in mind, is a good way to think about how to choose which type of dialysis might work best for you, your goals, and your situations. You can also see on the slide, I have little arrows kind of between the different types of therapy. And that's kind of to give you the idea, the sense that when you choose one of these things, when you go on one of these types of dialysis, you get a kidney transplant, or even if you choose conservative care, that is not a final decision. You can change to something else if that particular type of care is not working for you and it's not fitting with your goals, your lifestyle, your situation. So it's important to know that you can move between these different types of therapy. That's something that you should always keep in mind as you're doing any of these, thinking, gosh, is this working for me? Is this bringing me the health that I think works for my life? And do the risks and the challenges of the therapy I'm doing, do those things outweigh the benefits I'm seeing from them? Or am I feeling good on this and I want to keep it going? So important to know, these are not final decisions. You can switch between the different options. I want to put this into a little bit of a bigger context. All these options that we have for kidney replacement, should you have progressive advanced kidney disease. Many of you are probably well aware of this particular executive order. It was called the Advancing American Kidney Health Executive Order, issued by the president in 2019. This is a major piece of policy that really emphasized the importance of reducing the risk of kidney failure. Like we talked about, mission number 1 is protecting your kidneys. Set out a goal in this particular executive order of reducing the risk of going on to dialysis or needing a transplant by 25% by the year 2030, reducing that number of new people having to start dialysis or get a kidney transplant by a quarter by 2030. That was one of the things that the executive order laid out. It also laid out the importance of improving access to and quality of person-centered treatments for kidney failure. In particular, it laid out the goal of, by the year 2025, having 80% of folks who need to start on dialysis or a transplant start with either home or with a kidney transplant. So this is a pretty big, audacious goal to move towards that. And then number 3, third big bucket there, is increasing access to kidney transplantation and doubling the numbers of available kidneys by the year 2030. So this executive order, really a major piece of policy. There have been some adjustments and new payment models that Medicare has put forth to try and support these big buckets of these big buckets that I've described here. And a really important thing for us as a kidney community to know that this is out there, and there are things that are flowing from it and changing the way that kidney care professionals approach how they think about kidney care. And all of these are really aligned with, I think, what a lot of us have thought about for what we should be doing to bring the best care to people with kidney disease for many years. So it was nice to see this laid out kind of in policy. As I was mentioning, there are many options for people who have advanced chronic kidney disease who might need some kind of kidney replacement therapy. And one of the best options, if it's right for you, is a preemptive kidney transplant, meaning getting a kidney before having to start dialysis. And, this has a number of clear advantages, including, obviously, avoiding dialysis itself. So you don't have to go through the disruption of starting on dialysis, the procedures, the potential complications that can come from it. So it's a good thing to be able to avoid all those things if you can. And particularly for people of childbearing age, it's one that preserves fertility for both men and women, which is, of course, really important for folks who are in their childbearing years and thinking about having children. It's one that allows you to stay employed, keeping you at a quality of life and with a disruption to your schedule that's really minimal after the transplantation itself and the early period. So it allows you to stay employed. And it's associated with a higher quality of life and a longer life, as compared to dialysis therapies themselves. So if we can get a kidney before we even start dialysis, gosh, that's what we want to do if it's the right thing. And there are certain people for whom this is not the right thing. So really important to talk to your doctor about your particular situation. But this is an important one to keep in mind if you're someone who is dealing with the challenge of progressive and advanced chronic kidney disease. This is a really nice resource I just wanted to briefly highlight from the National Kidney Foundation. I think, in order to get a preemptive kidney transplant, we often need a living donor. It's unusual, it's possible, but unusual to get a deceased donor preemptive transplant. So usually this means having a living donor, and that can be a difficult conversation for some people to have with friends and family members. So this website that the National Kidney Foundation has a number of videos from both people who have received kidneys and donors who have given kidneys that kind of talk about how to have this conversation, because it is a challenging one. So this is a nice resource for folks who are looking to have conversations with their loved ones about potentially donating a kidney. So I just wanted to highlight this for people in case you hadn't seen it before. It's really nice, lots of good videos and information on the site. So say kidney transplant is not an option. Preemptive kidney transplant is not an option for us for whatever reason. Perhaps we don't have a living donor or dialysis started too quickly to arrange that. An important question is, what kind of dialysis would kidney professionals do if they were faced with that scenario while they were awaiting a transplant from a deceased donor? And if you ask nephrologists and nephrology nurses what type of dialysis they would do, the answer overwhelmingly comes back that they would do some kind of home dialysis. So you can see on this survey here, this is one that was done by my friend and colleague, Dr. Brigitte Schiller, who is our chief medical officer at Satellite Healthcare. She did this study now, gosh, just about a decade ago, and it's been done a number of times, this particular type of survey. And you can see here that 50% of the nephrologists said they would do some form of home hemo, 43% said they would do some kind of peritoneal dialysis. So there you go, you got 93% of nephrologists saying they would do some form of home. And you can see similar types of numbers coming from the nephrology nurses, and much smaller percentages saying they would do some form of in-center dialysis. So I think this is important to keep in mind, because the folks who see and manage a lot of dialysis, home dialysis is the kind of dialysis they would do if they were faced with this choice. Now, this doesn't mean that home dialysis is right for everybody, because obviously everybody's situation is different, everybody's goals are different, etc. But I think this is a good piece of information to kind of tell us about the way that people who deal with dialysis all the time kind of think about how they would provide care to themselves or a loved one if they were faced with this choice. So really important that you be empowered with this information and know that this is the way that a lot of kidney professionals look at it. Now, subsequently, you would think, gosh, well, if that's the way kidney professionals think, don't we have a lot of people who are doing home dialysis? And in the United States at the moment, it's about 13% or so of people do some form of home dialysis. You can find the United States just about, oh gosh, a third of the way down on this particular slide. In the blue there, you will see the amount of peritoneal dialysis that we do. It's somewhere about 10% of people who have end-stage kidney disease do some form of PD. And then in the red there are people who have received a kidney transplant, and that's the type of kidney therapy they're getting for their end-stage kidney disease. And then in the green is home hemo, which just a small fraction of people in the United States do, somewhere around about 2% or just a little less. And then the remainder are on in-center dialysis. Now you can see this is quite different from other countries and areas of the world. You can see, for example, Hong Kong at the top of the slide. Gosh, it's almost 45% of patients are doing some form of PD. So a really high percentage of patients with end-stage kidney disease doing PD, you can see a chunk of them have a transplant, and then there's smaller numbers that are in center or doing home hemo. So there's quite a bit of variation across the world in terms of the percentages that do home therapies. And there are many nations that are sort of socioeconomically similar to the United States. So you can see New Zealand, Canada, Australia, all above the United States in terms of the percentage of people that are doing PD or some form of home with home hemo. So there's quite a bit of variation that's out there. And this may at least partially be due to the way that their systems are set up and how the culture of nephrology kidney professionals really helps to support patients on home therapies, which I think here in the United States, we're looking to do more of, as we kind of talked a little bit about what's in that executive order from 2019 laid out in policy. It's something that the United States is looking to get better at. And here's kind of the big split, in dialysis therapies. Gosh, you can do some form of dialysis at home, or you can do dialysis in a center. And our two major types of dialysis at home are peritoneal dialysis and home hemodialysis. So either the blood-based kind of dialysis with home hemodialysis or peritoneal dialysis, where we use a small silicone catheter that's inserted into the belly and then uses the body's own natural peritoneum to do the dialysis by putting in fluid, letting it sit, and then draining it out. These are the two sort of major types of home dialysis. And why would we think about these home dialysis modalities? Here are some of the reasons that we might potentially consider peritoneal dialysis first. First of all, this is a therapy that doesn't involve any needles or blood to do the dialysis itself, and I think that's real important, because there's very few people who are like just totally okay with needles and blood. Almost all of us have at least some reservation about those things. So having a type of dialysis care that doesn't involve needles and blood is certainly an advantage in that we don't have to deal with those anxieties when we're doing this type of care. It also uses the body's own natural peritoneal membrane to do the dialysis itself, instead of exposing the blood to an artificial dialyzer and tubing outside of the body. It's a simple therapy. I'll show you in subsequent slides, but most people learn how to do PD over the course of 2, maybe 3 weeks. It's a therapy that allows for a lot of flexibility in terms of schedule. So it can be done at night. Exchanges can be done during the day. They can be moved around in terms of timing to allow people for more time for work, life, travel. And these, of course, are important things for all of us as human beings. And it presents fewer transportation challenges than does in-center dialysis, where you're often having to shuttle back and forth between a dialysis unit 3-4 times a week. You don't have that when you're doing PD. You have fewer visits that you have to travel to the dialysis center in order to get your care. Usually patients who are on peritoneal dialysis, they're visiting the dialysis center maybe 1, 2, maybe even 3 times a month, perhaps on the more busy side, but many patients are just visiting the dialysis center once or twice a month. So many fewer trips involved in getting the care you need when you're on PD. I think really important with both PD and in-home hemo, these are therapies that really empower you with control over your own care. You're the one taking care of the dialysis, or you're a loved one or caregiver who's helping you. And this is critical. This is really critical, because no one takes as good care of you than you. You are the person who can really take good care of yourself, because you care about yourself. Other people, other professionals, of course, can do a good job, but there's nothing quite like being empowered and owning your own care, understanding your dialysis, understanding the medicines that are related to your kidney disease, and taking control over them. So I think that's an important thing for both PD and home hemo. PD in particular, it does a really good job of preserving the remaining kidney function when you compare it to hemodialysis. So peritoneal dialysis is a gentler form of dialysis. It takes fluid off much more slowly than does hemodialysis. And as you can see in my next bullet point there, it causes much less to no stunning of the heart versus hemodialysis. That there have been good studies that have been done now looking at what happens to the heart during hemodialysis when fluid is quickly removed. And what you can see is little changes in the way that the heart wall actually moves, and what we call stunning. The walls don't move quite as well when the fluid is quickly removed with particularly 3 times per week in center dialysis versus peritoneal. And we think perhaps because of this, we see better preservation of remaining kidney function, which is really important. Any kidney function, even if it's just a small amount, is important because it helps you feel better, helps you have a more diverse diet, and is associated with longer life. So preserving remaining kidney function is really important. Peritoneal dialysis also is a kind of dialysis that requires less in terms of potassium restriction. In fact, many people who are on peritoneal dialysis tend towards lower potassiums because we're just constantly removing it with the dwells that are put in place into the belly, the fluid that's put into the belly that then pulls across both potassium and other toxins that we need to remove from the body. Not to say potassium is a toxin, but other toxins that build up in the body. So there's less potassium restriction oftentimes with PD, which is another good thing because, we all like, well, I wouldn't say we all, but most of us like tomatoes and avocados and potatoes, and gosh, maybe we want to have a coconut water every once in a while, like, these potassium rich foods. So there's less potassium restriction oftentimes with PD, which is a potential advantage. It's also a therapy that's associated with fewer dialysis access interventions, meaning with hemo, we either need a catheter, a fistula, or a graft, something that goes into the bloodstream to allow us to access that bloodstream. And oftentimes these types of access, they'll require some procedures, both to place them, to help them get ready to be used, and then subsequently to keep them working. And with PD, oftentimes we need fewer procedures to get that dialysis access working. Once we put in that peritoneal dialysis catheter, oftentimes we can keep that working with just one, maybe a couple of procedures a year or less, versus the hemo access, which sometimes is requiring far more. So this is an important potential advantage because no one likes having to go to the doctor or the procedure center to get something dealt with if it can be avoided. PD is also associated with a higher quality of life and satisfaction with care versus 3 times per week in-center hemodialysis. And people seem to live about as long on PD versus hemo. These things, when you look at the survival curves, they're basically about the same when you adjust them for all the various things that are different between people who do PD and in-center dialysis. So these are all important regions to potentially consider doing peritoneal dialysis first. Now, there is an elephant in the room with peritoneal dialysis that I'm sure at least one person on the call has heard, and this is this issue of, hey, if you do peritoneal dialysis, we're really worried that you're going to get an infection. And this is something that people often hear from, gosh, maybe another person who's done dialysis, maybe it's from a family member, maybe it's from a physician even. This is a common thing that is out there when people talk about peritoneal dialysis, and it's important to realize that the risk of peritoneal dialysis in this day and age, in terms of peritonitis and the severest kind of infection you can get when you're on PD, is actually lower than the risk of getting a bloodstream infection if you have a catheter and are doing in-center hemo. So this is just looking at the various infection risks across the different kinds of dialysis access. So you can see the very lowest risk of an infection would be a fistula, a little higher risk if you've got a graft for a bloodstream infection. And there and here, if you've got a central venous catheter, gosh, we've got that's the highest risk for infection of anything. And then if we look at peritonitis, the risk is a little lower if you look across the entire United States. And then this is actually looking at our peritonitis risks at satellite healthcare, where we have, on average, about one event every 5 years. So this is actually quite an unusual, not common event now, particularly with good training and care. That's not to say it doesn't happen, but it is much less common than it was in years past. And an important difference between a peritonitis episode and a bloodstream infection episode is that peritonitis episodes, oftentimes we can treat with antibiotics that we put into the belly there, into the peritoneum, and they don't require having to go to the hospital. We can oftentimes treat them that way. Versus a bloodstream infection, which can be incredibly severe and lead to incredibly severe complications. Things like infection of the heart, infection of the brain, etc. So peritonitis is a complication that is less common than it was in the past. It is less likely than a bloodstream infection should you be dialyzing with a catheter. And it is a type of infection that oftentimes can be treated with outpatient therapy and not require a trip to the hospital. Now, there are, of course, exceptions to this, but important things to understand about peritonitis. Because the myths are out there, and it's important to know what the risk actually looks like and is. Exercise on PD is often something that comes up, and we love it when people exercise on PD. In fact, I have worked closely with many of my colleagues at Satellite Healthcare to actually put in place exercise programs specifically for people on PD. And we also encourage people now to swim on PD too. This used to be something that some folks were a little bit hesitant about, but we actually love it when people swim. It's an important form of exercise, and it's something that you can do safely with the right instruction and care from your nurse and dialysis care team. And we now say that it's okay to swim in oceans, chlorinated pools, rivers, lakes. We say that's all okay, as long as you get the good instruction about how to take care of your PD catheter when you're doing this type of swimming. The only thing we say is a no-no really is hot tubs and jacuzzis. And the reason we say so is because the things we use to protect the peritoneal dialysis catheter and the other types of swimming oftentimes can come off in hot environments. Like the stickiness of them the adhesive can wear off and they can fall off. So we encourage people to exercise on PD, and we love it when we love teaching people how to swim safely on PD. So these are barriers that have, people will throw up as to why maybe don't do PD, but we actually think they're things that you can do on PD and do safely. So important to know about this as well. Also important to understand. So we've talked a lot about peritoneal dialysis. There are lots of reasons that one might think about doing PD. And it's a great therapy for many of the reasons that we've talked about. But when you start thinking about, gosh, what might more closely approach the function of a normal kidney? Here on this slide, I'm kind of showing you what 3 times a week hemodialysis achieves. And gosh, it kind of gives you kidney function that's, roundabouts, GFR of around 10 or so, something like that. PD is pretty similar. PD is done every day of the week, typically, though some people do it a little less frequently. And it's pretty similar to hemo in terms of the amount of clearance and toxins that it provides. But when you start getting into more frequent and longer hemodialysis that can be done in the home, more intensive dialysis, there the kidney function starts to get up into a range where it's closer to stage 4 or even stage 3 CKD, giving you much more close to what you might achieve, with your own kidneys. And of course, transplant is almost taking you back to normal, not quite, but almost taking you all the way back to having totally normal, healthy kidneys. So more intensive hemodialysis, which can oftentimes be done in the home, is kind of a step between PD and that kidney transplant. And because of that, it has a lot of potential advantages. So, when you're doing dialysis 3 times per week in the center, um, there's that 2 days off. And those 2 days off are associated with higher rates of cardiovascular events. That's what I'm showing you here in this slide. You can see where the little blue area is, a little blue line there is slightly higher on HD1. That's the day after the 2 days off. There's higher rates of cardiovascular events, higher rates of hospitalization, and higher rates of all-cause death actually after those 2 days off. And that's something that we can get rid of if we dialyze more frequently. We don't see this pattern with 7-day-a-week PD or home hemo or more intensive in-center dialysis greater than 3 times a week. And part of the reason behind this is it may be that, with 3 times a week dialysis, you can see stunning of various organs. We talked a little bit about the heart. It can also happen with other organs. The kidneys, we talked a bit about that. PD may preserve remaining kidney function better. 3 times per week in-center dialysis also associated with decreases in blood flow to the brain. So dialyzing more frequently, more slowly is something that can help to potentially minimize these types of effects on important organs in the body. And this is why intensive home hemodialysis is a really important option that has a lot of advantages that we should think about. So similar to PD, home hemodialysis is one that allows for a flexible schedule. You can do the dialysis when it makes sense for your life, for your work, your travel schedule. And this is important for us as human beings. Everybody has these things in their life in some way, shape, or form. So the flexibility to be able to do them is important versus being tied to a very strict schedule in an in-center hemodialysis unit. When we do more dialysis, and the amount of clearance of salt, water, toxins, potassium, etc., is high, then we don't have to restrict the diet as much. So if you're really dialyzing long hours, multiple days of the week, gosh, you can eat pretty darn normally and not have problems with phosphorus, potassium, etc. Gets rid of that 2-day gap, which can be such a problem on the 3 times per week in center side. Because the dialysis is slower, gentler than is what is done when we try to do everything 3 times per week, when you do dialysis at home more frequently or longer, there's less recovery time after the dialysis itself. So it's not unusual when you talk to, or if you yourself have experienced this, if you're on 3 times per week in center, it's not unusual that someone feels pretty tired and wiped out for a period of time after the therapy. Some people will say, gosh, it even takes me a whole day to feel normal again after I do my dialysis session. And we see much less of that when we do dialysis more slowly, more gently at home. And we see this manifest in a whole bunch of different ways in terms of quality of life things, like people have improved sleep, better physical and emotional well-being, and lower depressive symptom burden when they dialyze more frequently at home. And we see people need to take fewer pills too. So less blood pressure medicines, less phosphate binders. Gosh, who wouldn't love that? Less phosphate binders when you're dialyzing more frequently, longer hours, because gosh, we can just take care of that phosphorus with dialysis. And there's even the suggestion when you look at studies that how long you will live on dialysis is actually longer if we do intensive hemodialysis at home. And we don't have the perfect randomized prospective trial to prove this, but the weight of the evidence in the retrospective trials really suggests that people may live longer if they do take on this more intensive, longer dialysis in the home versus 3 times per week in center. So an important thing to know and understand. Now, I think we've walked through sort of the advantages of peritoneal dialysis and home hemodialysis are types of treatments. And they do have different flavors. So when we talk about peritoneal dialysis, this can either be done as what we call continuous ambulatory peritoneal dialysis, CAPD. What this is where you without a machine, just use gravity to hang bags, as you can see in the picture there, and connect those bags through a small attachment to your peritoneal dialysis catheter, a small catheter that's inserted into the belly. And you use gravity to flow that fluid into the belly, let it sit there, usually for about 4 to 6 hours, something like that. And then drain that fluid out using gravity. And people do somewhere between 1 and 4 exchanges, maybe 5 exchanges a day. That's continuous ambulatory peritoneal dialysis. It's a really simple way to do PD. Now, it does require you to do the exchanges oftentimes during daytime hours. So for some people, it's more convenient to use a machine to do the exchanges oftentimes overnight. So we typically call this continuous cycler peritoneal dialysis, or CCPD. And on this one, there's a machine. It's about the size of, a printer, maybe a little bigger than that, that you use to move fluid in and out of your belly overnight while you're asleep. And then during the day, often free without having to do exchanges. Though there are people who use the cycler and will do perhaps a manual exchange or two during the day if they need to do them. But often many people who are on cycler PD will just do the cycler overnight and then be free from having to do exchanges during the day. There are some people who will have some fluid that'll sit there during the day, but they won't do any exchanges till they get back on the cycler the following evening, and they drain that fluid out that sat there during the day. So these are kind of the two major types of PD. On the home hemo side, you can do home hemodialysis during the day or the night. Oftentimes, home hemodialysis that's done during daylight hours is done more frequently, not always, but oftentimes. Many people who are on home hemo during the day do something like 4 to 5 sessions per week. And usually the more frequently we dialyze, the better our outcomes are. So we encourage people to think about dialyzing more frequently to really improve how they feel and how they'll do long term. Dialysis at night is a wonderful way to do dialysis, hemodialysis. You can do longer hours, really take out more salt, more potassium, more phosphorus, more of the toxins that build up. And so home hemo can be done at night, which is a fantastic way to do hemodialysis as well. Another important advantage of the various home modalities is it's one that's allowed folks to stay safe during this current pandemic that finds us all here on Zoom, having technical difficulties with getting our slides going. Staying safe at home during the COVID-19 pandemic is something that patients who have been on home therapies have really been able to do. Now, that's not to say that people on home therapies have not gotten COVID and not had challenges with that, but it is one that allows us to stay out of and away from other people who might be sick when we have big surges in cases like we're experiencing right now with the Omicron variant. So this is an important thing to keep in mind as you're thinking about the different types of dialysis. I touched on briefly about how long it takes to learn how to do these types of therapy. Most people learn how to do peritoneal dialysis in 2, maybe 3 weeks, something like that. Home hemodialysis, usually around 4 to 6 weeks. Again, these are averages. Some people take less, some people take more, but these are around the amounts of time it takes to learn how to do these types of home dialysis treatments. I have a little bit of data that kind of looks at the average number of treatments or training sessions that most people use. So this is from what's called the U.S. Renal Data System Annual Data Reports. This is a big report, comes out every year, that looks at data from everybody who's on dialysis in the United States. And this particular figure is showing us the number of training sessions that people on peritoneal dialysis accumulate. And what you can see there is that, gosh, it's about 75% of people have 8 or less training sessions that they accumulate over their time on dialysis on PD there. And usually those 8 sessions, they're usually spread out over a couple of weeks, say 4 training sessions a week. And then there's a smaller number of people who take more training sessions to feel comfortable and safe in going home with PD. So just reinforcing that point, it takes about 2 to 3 weeks to learn how to do PD. Here's the same data looking at home hemodialysis. And here you can see really the highest percentage number of training session there, 18% of people. It takes 17 to 20 sessions in order to learn how to do home hemo. And if you think about 20 sessions spread over 4 weeks, that would be 5 training sessions each week. You do one every weekday, but perhaps a little longer if you're spacing the training sessions out a little more. So again, just reinforcing the point that the amount of time that it usually takes to learn how to do home hemo is around 4 to 6 weeks. And usually when it takes a bit longer, it's oftentimes focused around comfort in learning how to access, how to do the needles for a fistula or a graft, if that's what's being used for the blood access. Patients who are doing home hemodialysis at home with a central venous catheter, which there are patients who do that, the training sessions often will need to be less because it's a little simpler to learn how to use a catheter versus learning how to consistently do the needles for a fistula or a graft. So important just to know kind of what the expectations are up front with the training time that it takes for home hemodialysis. This is a slide that just kind of looks at the amount of time that dialysis will take out of an average person's week for the different types of therapy, taking into account the actual dialysis itself and the time it takes to do get connected or disconnect from the various types of dialysis, the time that it takes to travel back and forth between the clinic if you're going to when going to clinic visits, and then the time it takes to recover after dialysis sessions. And you can see that in-center dialysis, oftentimes you're approaching 30, 35 hours a week, but mainly because of the big bulk of time that it takes to recover after dialysis sessions. With home hemo and peritoneal dialysis, the time that it gets taken out of the week is less because there's much less of that recovery time, even though you're perhaps spending a bit more time on the dialysis itself. So important to understand this lay of the landscape for how much time gets taken out of the week around the different dialysis therapies. And these are averages. Some people take more, some people take less in these various categories, depending on exactly how they do their dialysis and how quickly or not quickly they recover from in-center dialysis, say. But these are rough averages to give you a sense of the amount of time that you end up committing to these various types of dialysis. An important question is there anyone who really can't do peritoneal dialysis or home hemodialysis? And the take-home message here is that there really are very few absolute contraindications to either of these types of treatment. Now, certainly, if you don't have an abdominal cavity that can support a peritoneal dialysis catheter because of, let's say, really active inflammatory bowel disease, that's a reason that peritoneal dialysis can't be done. Or on the home hemo side, if you have no option for a fistula graft or catheter, if we just can't get vascular access, that's a reason we can't do hemodialysis. Other things oftentimes are barriers to these therapies at home that can be overcome if we work at it. So for example, if someone doesn't have a care partner, well, gosh, both PD and home hemo can be done solo with good support from the dialysis center, good training for the person who's going to do the dialysis itself. That's something that can be overcome. And there are a variety of things that are like that potentially are barriers to both PD or HHD that we can overcome if we work to understand what that barrier is and we put in place the right strategies to help to address it. So I think for people thinking about the different kinds of dialysis, it's important not to rule yourself out for one of these, because you say, gosh, there's just no way I could do that one because of X, Y, or Z. Important to talk to the folks who will be helping you with dialysis to see if the barriers that you perceive are really ones that can't be overcome. And if you're being told by the dialysis center or nephrologist, gosh, you can't do it because X, Y, or Z, important to really think about, gosh, is this really an absolute, or is this something that potentially could be overcome if we put in place some kind of creative fix to it? So I think that's really the important message here. Um, uh, because of the potential advantages of both PD and home hemo and a variety of other things that have happened through the years, we've really seen a growing prevalence of people on home dialysis really for the past decade. So now we've got, in the most recent data from 2019, 13.1% of people who are on dialysis are doing some kind of dialysis at home. And this is kind of showing you that slow upward curve of the percentage of people who are on home therapies growing from, gosh, just over 8% up to that 13.1% in the most recent information. And the bulk of people who do dialysis at home are doing peritoneal dialysis, 11.2%. And 1.9% of people who are dialyzing, 1.9% of our total population on dialysis are doing home hemo. Just a quick word about home hemo, because there have been some interesting advances in this recently that I think it's important to be aware of. So we now have 3 different hemodialysis machines that can be used in the home. These are all FDA approved for use in the home environment. And they are the Fresenius 2008 K at home machine, the next stage machine shown there in the middle, and then the most recently FDA approved machine, the Tableau machine, which was approved just back in 2020. So we've now got 3 different devices that are approved for use in the home. In addition, there are more home hemo machines currently in clinical trials. So I'm showing here the Quanta machine, the Hemo machine, HemoCare machine, and the DIMI machine. All of these are ones that are currently or entering into clinical trials to be FDA approved for home use. And the reason this is important for folks is because all of these kind of have different pluses and minuses to them that may make them helpful for different people to allow them to dialyze in the home. So for example, the Fresenius machine is one that's been around for a long time. It's a very reliable machine, very flexible in terms of the intensity of dialysis that it can prescribe, but it is a little more complicated than many of the other machines. The next stage machine is one that's portable, so it can be taken on trips. It allows the use of either packaged dialysate or the production of dialysate from the home's water source in that little black unit that you see at the bottom of the picture there. It's called the Pure Flow unit. It's a unit that actually produces dialysate from the home's own water and dialysate concentrate. And it's FDA approved for both solo use at home and for nighttime use. So a number of different advantages to the next stage machine. The Tableau machine is really designed to be a very simple machine. So it has a touch screen that walks you through every step of setup, treatment, takedown, and maintenance of the machine. So it's really designed to be easy for staff and patients to use. And instead of using packaged or batch produced dialysate, it actually produces the dialysate on demand from the home's water source. And different from the Fresenius machine, the water treatment unit is all in the bottom part of the machine. It doesn't require a whole separate water treatment unit. So it's a little bit less intensive than the Fresenius machine in terms of what has to go into the home for water processing. So potential advantages there. The newer machines that are down the bottom there all have their own things. The Quanta machine allows a faster flow of dialysate, which perhaps provides a bit better clearance. It's also designed to be simple, similar to Tableau. The HemoCare unit in the middle there is designed for nighttime dialysis specifically and has a number of safety features to help support that. And then the DIMI machine that's over on the right there is an interesting one. It's actually designed to be both a peritoneal dialysis cycler and a home hemodialysis machine. So you can do either type of therapy with it. So all of these machines kind of have their interesting pluses and minuses. And it's exciting for us in the kidney care community because now we've got more options for how we can provide hemodialysis in the home. And it'll be great to see these new machines come into the market and being available for patients to use, because they will provide us with more options to tailor to each individual's specific situation. So really nice things to know about in terms of development of technologies that have occurred over the recent years. Also important to know that legislation, in addition to that Advancing American Kidney Health Initiative, we've now seen another piece of legislation, the Improving Access to Home Dialysis Act, which was put into the House of Representatives just in September of last year. This is a wonderful piece of legislation which will provide financial support for assisted peritoneal dialysis and assisted home hemo, meaning the payment for staff professionals from dialysis providers to actually come out to the home to support people to do these types of dialysis at home, which will be a wonderful way to help to support more people dialyze at home who perhaps don't have a care partner and aren't comfortable or safe to dialyze on their own. Or need that little extra bit of support. So this is an exciting piece of legislation, which hopefully will help to further expand the ability of the kidney community to offer dialysis treatment in the home with more support. So keep your eyes on this one. It's an important one. Also, I talked a little bit about a call to action at the top of the talk here. You know, I think all of us as people with kidney disease, people who take care of kidney disease, we should all be advocating for things that will help to support and expand great options for patients to get good care. And this is a really interesting model that exists in New Zealand. This is called community house dialysis that's done in New Zealand. And it's really interesting. The way it works is that local kidney charities partner with local district health boards, and the charitable societies have actually purchased and maintain homes in multiple different areas of New Zealand. And these are just houses out in the community that the charities have purchased and then they maintain. And the district health boards outfits these homes with dialysis machines and supplies so that patients can then come to these houses with or without caregivers and do their hemodialysis in these houses. And patients are then responsible for their own dialysis and cleaning up after the machines, but there's no technicians or staff there doing dialysis for people. Instead, this is a way for people to do dialysis in a home environment without having to own a home that has the space or the water requirements to put in a hemodialysis machine. So it's really a great way to expand access to home hemodialysis, self-care, to people who don't necessarily have the home or the space to do it, but yet who want to take control over their care and do self-care. So I think this is an important one for all of us to be aware of as advocates, because gosh, wouldn't it be great if we told the regulators, this is something that we really want available here in the United States. We want the ability to do this because there are many communities where people just don't have the house or the space to do dialysis. They're renting a property or they own a smaller property where they just can't have a hemodialysis machine in the house. And this is a way to potentially expand to more communities the ability to do self-care and hemo in the home. And when this type of care has been looked at in New Zealand, it has a number of different benefits from the patient perspective. The community of people who go to do dialysis at these types of houses support each other. They provide real peer support. They often encourage each other to think about doing longer and more frequent dialysis based on their own experiences of how those things bring them benefits in terms of their quality of life and how their health is doing. And it provides them with a whole supportive community, similar to what can develop on an in-center unit, but in a self-care home type environment. So I think this is a wonderful one for us to think about as individuals who are part of the kidney care community, and to talk to our organizations who advocate for various changes to regulations in the US about a great option that's there, that could potentially be wonderful to have here in the United States. I just want to close by saying, people of course have the fear when they are having progressive decline in their kidney function is, gosh, what is my life going to be after my kidneys stop working? This is a really scary thing to have to contemplate. And the answer to, is there life after my kidneys stop working, is yes, absolutely there is, but it's going to be different. And knowing your options and choosing the one that's right for you, whether that be a preemptive kidney transplant or PD or home hemo or in-center or conservative care, knowing your options and choosing the one that's right for you is a way that you can really empower yourself to take control of your care and get the best possible care for your particular situation. And realizing also that if whatever you choose is not working, it's something that can be changed, and to something that does work for you. And that's part of the job of the nephrologist and the kidney care team, is to help to support you in making sure that you're getting the best kind of dialysis care for your life. So with that, I'll go ahead and close. Again, apologies for the massive technical difficulties, and I'm more than happy to take any questions.
Hi, Dr. Abra. We have some questions in the Q&A. I think some of them that you have already answered. Hold on, I'm trying to see them. Everybody's very excited about that you can swim with PD. That was something new for me learning also.
Yes.
So one person asked, we were told that it means you cannot swim and that problems with water quality. I think you answered that. But what about salt water? I assume that's okay since oceans are okay? A saltwater pool?
Yes, that's correct. So this is an important one to speak to, because this is swimming on PD. There's a lot of myth and legend that's out there around swimming with peritoneal dialysis. And I think first, it's really important to recognize that there are no high quality studies that are out there that really look at this and help us to understand what that risk actually looks like. But when we look at places that allow a lot of swimming on PD, a good example of this is Australia. Gosh, there, when you look at the people who are on PD there, most of the units that are there allow swimming on PD. And they do so by providing folks who are doing their PD with strategies for how to keep the PD catheter safe during the swimming. And usually that means having either a colostomy bag fixed out over the PD catheter to keep it safe and dry, or a totally occlusive adhesive dressing that goes over the PD catheter and keeps that catheter safe, dry along with the exit site, followed by, after the swimming is done, removing that colostomy bag or adhesive dressing, and then doing good exit site care afterwards to ensure that no bacteria might have snuck in there. And because you can do really good care with either of the strategies I described there, we actually think it's fine to swim in any of the environments you were mentioning: the ocean, a stream, a chlorinated pool, a saltwater pool, etc. As long as you're doing that good care over the PD exit site with a colostomy bag or an adhesive dressing that your nurse teaches you how to do, and then good exit site care afterwards, we think that keeps the risk of getting an exit site infection pretty low. So that's why we've kind of changed our stance a little bit on that one and said, gosh, we want people to swim because it's great exercise, it's fun, but let's if we can do it safely, then let's do it. So that's sort of the reasoning and the rationale behind that one.
That is wonderful news. I know a lot of people are going to be happy to hear that.
Yeah, and what I would say about it is critical to talk to your peritoneal dialysis nurse and your nephrologist to get the training on how to how to care for that PD catheter when you do go for the swim. We at Satellite Healthcare have a whole policy and procedure on how to do this, and we actually provide people with colostomy bags if they're interested to do this type of to do the swimming.
So does sweat from exercise cause an increased risk of infection?
That's a great question. And in general, no, as long as you're doing good daily, regular exit site care, which for most people, that includes using something like Accept, a dilute bleach solution to clean the exit site, plus minus, some topical antibiotic cream to the exit site each day. Typically, sweating a little bit is not going to increase your risk significantly of getting an exit site infection. And the benefits of exercise far outweigh any small increased risk that might be there from my perspective. Because, exercise has, as we all know, lots of great benefits, right? It helps our hearts, it helps our mood, it helps our strength, our balance, etc. So we don't want to be holding off on exercise because we're worried about that exit site. Of course, we want to be careful. Let's not tug on catheters and this kind of thing.
Right.
You got to be careful, but gosh, let's exercise.
So is hemodialysis better for you physically than peritoneal?
That's an excellent question. And I think it all comes back to this idea of individualizing. There probably is no one best therapy, but all of them have their pluses, minuses, advantages, disadvantages. And the thing about peritoneal dialysis is that, gosh, it's a pretty simple therapy, preserves that remaining kidney function pretty well, and we don't need access to the bloodstream. So it's wonderful for all those reasons. Hemodialysis that's done really intensively and really frequently, it does seem to remove, we know it removes more toxins, more fluids, seems to have benefits to the heart, and does seem to be associated with better survival. So for some people, taking on the burden and the challenge of doing more frequent intensive dialysis is a wonderful way to do it. It is important to acknowledge, though, that it has its own risks, right? So you're accessing the bloodstream. So there's a risk of bloodstream infection when you're doing either hemodialysis in the home or hemodialysis in a center. So really meticulous attention to infection control is important. And there's also the risk of, with more frequent accessing of the bloodstream, that you may have issues with your fistula or graft or catheter more frequently than you would if you were dialyzing less frequently. So there's no perfect, and I wouldn't say better or worse. I would say that each one has its trade-offs, and at a particular point, each one of the dialysis modalities may make really good sense for an individual person, depending on what their clinical situation is and where they are in their lives.
It's truly an individual decision then.
Absolutely. I
evaluate yourself and your life and where you're at right now.
Absolutely. I try not to be prescriptive and say, like, this is the best and this is what you will do. Instead, listen, let's understand what the different options are and the pluses and minuses, and then let's make the best choice for you at this particular moment in time, understanding that, gosh, if we start with PD, we may want to go to home hemo after that doesn't work well for you, or potentially vice versa. So
that sort of leads into the next question of, can you switch forms of dialysis? And even if you're on a particular machine, can you switch between them?
Absolutely. So switching between the various forms of dialysis is absolutely doable. Now, there are potentially some practical things when we switch between different types of dialysis that you have to keep in mind. So, for example, if you're switching from in-center hemodialysis over to peritoneal dialysis, you will have to have a peritoneal dialysis catheter placed in order to make that change, right? Similarly, if you are going to be switching from peritoneal dialysis to home hemo, you'll have to have some form of blood access placed, like either a central venous catheter or a fistula or graft, in order to allow that home hemo to occur. So there are some practical things, but there's no clinical reason that we can't switch between the different types of dialysis therapy when it makes good sense for the individual person. So absolutely, switching is okay. What was the second part of that?
Second part of it is about the equipment. We've got a couple of questions about who pays for the machinery. Can you switch to a newer version if you already own an older one? Do you have to buy it? Just the cost associated with each type of dialysis.
Great question. So the equipment itself is covered by insurers and Medicare. So you don't, when you're doing home hemo or peritoneal dialysis, you do not have to purchase these machines. Instead, they are purchased by the dialysis organization providing your care, and they are reimbursed by Medicare or other insurers. So there is no cost for the machine to you. Now, where there may be some cost is important to realize. Sometimes modification has to be made to the home, usually not for PD, but sometimes or frequently, commonly for home hemo, some kind of modification needs to be done either for water or electrical. Many dialysis organizations will provide some subsidy for this, which may or may not cover that total cost. It depends how extensive the modification has to be, of course, in the home. But you do not have to purchase these machines. In terms of, which machine can you use? So it depends on your dialysis organization. So not every dialysis organization has access to all of the FDA approved machines, the Fresenius, the Next Stage, and the Tablo machine, because of contractual type issues. But some dialysis providers do have access to all of these machines. And if you're interested in using one of them, the way to find out is to talk to your dialysis nurse and ask, what machines does our dialysis organization have? Because I'm interested in learning a bit about, one of the different machines, whether that be, if you're on the Fresenius, I'd like to learn about Next Stage, or I'd like to learn about Tablo. Ask about them. You can look them up online. They've all got beautiful websites, of course. So you can look them up online as well. So that's the deal on the machines.
So we got a question: which machine is for overnight PD, and how long does it take each night?
Oh, great question. So I showed you the hemodialysis machines. I did not show a slide showing the different types of peritoneal dialysis cycler. So there are various different types of those. I didn't show a slide with that, but they're all pretty similar in terms of their size, in terms of the basics of what they do, moving fluid in and out of the belly. Some of them come with a few more bells and whistles. They have touch screens. Some of them connect to the cloud now and actually send you the results of your peritoneal dialysis session back to the dialysis center so that your nurse and your doctor can see those things. So there are some differences in the peritoneal dialysis cyclers that are used out there. There are two major manufacturers that make them. And again, it's sort of like the hemo machines, important to talk to your nurse about what options are available at your particular center and what the trade-offs are between it.
So actually, our first question of the day is, how is satellite dialysis different from DaVita and Fresenius?
Oh.
Person that asked didn't even know about satellite wellbound when they started dialysis.
Got it. Good question. So Satellite Healthcare is a nonprofit dialysis provider. So that's sort of the first and primary difference. So DaVita and Fresenius are both for-profit companies, meaning they are publicly traded on the stock market. And of course, that does create some differences in how the organizations approach their overall provision of care. So what I would say about Satellite as a nonprofit, we are truly mission driven. We were developed as a satellite organization to Stanford. It was founded by a Stanford nephrologist Now almost 50 years ago now, 45 years, 44, I think we're at 45. Yeah. So Dr. Norm Copeland was our founder. He was a nephrologist at Stanford who decided, gosh, why are people driving all the way from San Jose, all the way up to Palo Alto to get dialysis? This is crazy. Let's found a unit that is satellite to Stanford so that patients can receive care closer to their friends and family and their homes. And it was founded as a nonprofit with the mission to provide better care to people who are living with kidney disease and struggling with it. And it has carried forward that mission over the past 45 years or so, with truly the patient at the center of what we do. And that expanded subsequently to the well-bound units, which are centers that are just dedicated to home dialysis care. So all they do is peritoneal and home hemo. They do not do in-center. We have kept that at the core of how we approach dialysis care, and are not beholden to stockholders in any way, shape, or form in terms of our profitability, which is important, because it allows us to instead reinvest money in patient care and types of services that can benefit patients.
So how would I go to a satellite center versus a DaVita Fresenius? Would I need my doctor to refer me? You only work with certain insurance? How would that work?
No, so first I would say that you are in charge of your care. Number one, okay? You are the one, if you're the person getting dialysis, you're in charge of that. So you get to decide what kind of dialysis might fit best for you, where you might want to receive that dialysis based on your due diligence and your understanding of best advice from your kidney care team, your nephrologist, your nurse, other people who might be involved, your family, and then you get to decide that. How do you get referred in? Well, you can self-refer. You can call any dialysis unit and say, hey, I'd like to come take a tour. I'm a kidney patient. I want to see what you guys do, and I'm interested in learning. There's no reason you can't do that. Give them a call. Ultimately, to get care at a particular dialysis center, the nephrologist would have to prescribe dialysis at any, whether it be DaVita, Fresenius, Satellite, US Renal, all the different ones. The nephrologist has to prescribe that dialysis in that center. So if you did want to ultimately switch to a different center, you would, check it out and make sure it was right for you, and then talk to your nephrologist about a formal referral so that you could get your care at that particular unit.
Oh, thank you. Phil just stated he worked with Dr. Norman in a research lab at Stanford back in 1969. That's interesting.
That's amazing. That's amazing. His legacy is still, really at the core of our organization. Dr. Copeland was someone I got to know as a fellow late in his life before he passed away, and he touched many, many people across the kidney community. He was heavily involved with the National Kidney Foundation, and many patient organizations. And so I often find when talking to all kinds of people, whether they be people who have kidney disease or nephrologists or others, they had some experience with Norm.
Contact with him. So one last question, and then we'll end on a good note. This has been a great presentation. Thank you. What are the current practices regarding reuse of dialyzers, and what does the data show about the safety and efficacy of this?
Yeah, it's a great question. So satellite healthcare no longer uses reuse of dialyzers. We did for a period of time do reuse. We no longer do it. We stopped that practice a number of years ago now. It's one that does not, not something that we do in the home setting. So, most of our talk today was around peritoneal and home hemodialysis. And typically we do not reuse dialyzers in the home setting. In particular, both the next stage and the Tableau device both use cartridges for the dialysis tubing. The dialyzer comes prepackaged with the next stage machine. With the Tableau machine, you can use any commercially available dialyzer. Fresenius machine, you can use any commercially available dialyzer. And typically we don't use reuse in those settings. So there are a number of potential disadvantages to to the reuse approach, because it requires chemical cleaning of the dialyzer, which can introduce a number of potential complications for the patient. So although it can be done safely, there are potential risks to it. And for those reasons, we stopped using it a number of years ago.
Okay. So I'd like to read Dawn's comment. I'm not sure if everybody can read the Q&As or just us, but because it's so encouraging. She writes that my husband's been doing home hemodialysis 7 days a week for the last 4 years. We love traveling and have done treatments living in a camper for weeks at a time, and even camping in a tent and a motorcycle rally running on a generator. Dialysis is not a death sentence. It is a new normal. That is fantastic. I love that.
That's a wonderful comment. And, that kind of story, that kind of experience is really what we want to try to support for people who are living with kidney disease, because kidney disease is a hard disease. And we want people to live as full and as normal a life as they can with kidney disease, providing them with a treatment that really they can fit into their lives and allow them to do the things that were described just there. So that's one of the reasons I'm so passionate about home dialysis, is because of stories like that, and hearing people who really thrive doing the home therapies.
Well, this has been an excellent presentation. I know we started off rocky, but I've learned so much personally, and so I'm sure everybody else has too. It's great, the advances that are being made, and just it's exciting, that all this is coming about now. And thank you. That was a great presentation.
Well, wonderful. It's really been a pleasure. I see there's one question about travel here. I'll touch on it just quickly because it's important. So do patients on PD travel is basically the question. I'll tell you, I'll give you an anecdote. One of my personal patients actually is an Olympic diving judge. And this patient of mine travels the world judging diving across events, including the Olympics, international events. And he is constantly shipping his solutions everywhere, driving his nurse crazy, and traveling all over the place. So the short answer is yes, absolutely, you can travel while on peritoneal dialysis. It requires some planning, some logistics, but absolutely you can travel on PD, just like you can travel on home hemodialysis, which is an important part of the flexibility of these modalities. You can travel on in-center too, but it requires finding an in-center unit that you will go to at wherever placing that you are traveling to. So flexibility for travel is another wonderful part of both PD and home hemo.
Fantastic. I see other people are traveling has struck a nerve.
Of course. I mean,
we all want to, well, especially after COVID, we all want to travel.
Of course. Well, so here's the funny thing. It's like, all of these things are just basic things that we want to do as human beings, right? Like, we need to live our lives. We need to go to the grocery store. We need to go see our family, our friends. We got to travel places sometimes. Like, there's nothing crazy about any of this stuff. And only does it become like a big deal when suddenly we throw dialysis in there, because dialysis sucks up all this time and energy. And so we've got to talk about the types of dialysis that allow us to not disrupt our lives as much, in this big, crazy way, which happens much more with in-center dialysis because of the traveling back and forth, the rigid schedule, et cetera. Not to say that people can't do well on in-center dialysis, but the flexibility and the options with home really enable you to live a life that's much more flexible and able to take in the things that we all want to do as people.
That's a great summary.
Yes,
well,
indeed.
Thank you so much, Dr. Abra. We really appreciate it. this recording will be made available probably within the next week. Oh, good, we get to see you.
I'm brave enough now to turn it on because it like got through it. So it looks like it has not crashed.
You're a real person.
A real person, not just a fantasy, like a bot or something. Real person, just like all of you guys, just a real person, just dealing with dialysis and kidney disease.
Well, thank you. And we so appreciate all you're doing for kidney patients and for BAAKP in particular also. So the recording will be available in probably about a week. We'll be posting it to our website. And I'll be sending you a link if you want to share it with your patients also, Dr. Abra. So,
wonderful. Thank you so much.
Thank you very much.
Really my pleasure. And thanks for hanging with me through technical challenges.
We're so glad we waited. It was worth the wait. Thank you.
Thank you.
Bye, everybody.